Next, we have with us Professor Dr. Suresh Kumar, sir. Sir is an academician par excellence. Currently, he is the director at PsyMed Hospitals, Chennai. He is the retired professor of psychiatry from the Institute of Mental Health and Madras Medical College, Chennai. He has done his fellowship, a Hubert H. Humphrey Fellow in Substance Use from the Johns Hopkins University, USA. He has had extensive involvement in the field of mental health as a service provider, teacher, trainer, researcher, and as an international consultant. He has been working with several international and UN organizations such as WHO and UNAIDS. He has also assisted in substance use disorder treatment interventions in several countries such as Afghanistan, Bangladesh, Bhutan, China, Iran, Kazakhstan, Malaysia, Maldives, Mauritius, Thailand, and Vietnam, to name a few. He has published several articles in several international and peer-reviewed journals and is on the editorial board of International Journal on Drug Policy. Sir would be here giving us his valuable insights on the topic, clinical approach to alcohol and cannabis-related disorders. We are extremely honored and privileged to have you here with us, sir. Over to you, sir.
Thank you so much. And at the outset, let me actually thank Professor Shanti Nambi, Dr. Chandralekha, and Dr. Raman for inviting me to Saveetha Medical College CME on PGs. I'm actually delighted because this is the kind of exercise I'm looking forward to talk to postgraduates. And thank you very much, Saveetha Medical College and the faculty for giving me the platform. So I just heard Dr. Hema, as usual, brilliantly, she walked us through the clinical approach. So perhaps I will follow it up with the alcohol and cannabis use disorders. So the outline to the postgraduates would be, even though it's going to be a clinical approach, I will start with very basics to begin with, because I do not want you to make any mistakes with the basics. And I'll talk about how do you assess substance use in a clinical approach when you're having a long case. You should definitely assess the adverse consequences of substance use. I'm actually here in substance use, I'm only meaning alcohol and cannabis because the talk is limited to that. So I'll probably, you need to also, talk into the intoxication and withdrawal part of it. You must have to do a good mental health assessment because quite a lot of people have comorbid diagnosis. And then we also should be thorough with commonly used instruments and investigations in these patients. And should any long case, you should have a clear idea about the treatment plan. Without a treatment plan, I think you'll never be successful. So that's going to be my outline. So to begin with, to remove some confusions about nomenclature, people tend to use a word called substance misuse. When you talk about misuse, you're talking about, let's say, alcohol or cannabis being used at a very high dose. Also, in inappropriate situations, I drink in the morning, or I drink in a place where the family is gathering and discussing something very relevant, or it leads to health or social problem over time or immediately. So that's called a substance misuse. Misuse can lead to adverse consequences even after one use. For example, I may drink in a party, take my vehicle, meet with an automobile crash. That's also substance misuse, even though I used for the first time alcohol. Or somebody drinks and quarrels with his wife, or abuses a child, or attempts suicide, or has a stroke, or has an overdose. All this will be called as substance misuse. And I think you also will be using a word called binge drinking. This is also known as heavy session drinking. Heavy session drinking relates to having 6 or more standard alcoholic drinks. This is very important. 6 or more standard alcoholic drinks in one setting, in one session. And for men, it is 6 drinks or more. For women, it's much less. It is 4 or more. So if somebody having 6 as a man or 4 as a woman, and in one session, you call it as a heavy session drinking or binge drinking. So ICD-10 comes out with 6 criteria. If you have 3 or more of the 6 criteria, continuously lasting, persistently lasting for 1 month, or if it is not being continuously lasting, but evenly having for 15 days, 15 days, 15 days, doesn't matter, over a period of 12 months, if you had repeated episodes like this, then again, you can call it as a substance dependence syndrome. That's the word they use, substance dependence in ICD-10. The 6 criteria are a strong desire or compulsion to take a drug. So the desire and compulsion to take is one criteria. Difficulty in controlling the substance use taking behavior is another important criteria. The third is the physiological withdrawal state. And the fourth is the tolerance. And the fifth is the progressive neglect of alternative pleasures or interests. I'm not playing tennis any longer. I'm not interested in reading books. I'm not watching television. My only passion is towards drinking. That kind of a progressive neglect of other alternative pleasures or interests. Persistent with drug use or substance use despite the fact that it is harmful to you. So that's a very, very important one. So there are only 6 criteria, easy to remember: strong desire or compulsion, difficulty controlling substance use, withdrawal, tolerance, progressive neglect of alternate pleasures, and persistent use of substance despite harm. So 3 or more in the 1 month continuously happening, or periodically, like a lot of it happening repeatedly, you call it as a substance dependent syndrome. DSM-5 has 11 criteria. The 11 criteria are just an elaboration. If you look at the first 4, they're talking about either taking substance in larger quantities or for longer periods of time. It makes easy when you take a history rather than ICD-10 translating into a symptom, whereas DSM-5 straight away falls into a clinical approach. You can even straight away ask people how much of a quantity they take, do they take for longer duration of time, or do they want to cut down use at any point in time? Are they spending a lot of time on getting the drug, using the drug, or recovering from the drug? In 24 hours, these people are spending most of the time on substance use related activity, and there is craving and urge. This is one. And then there is also something like managing to do what one would manage to do at school or work or home. It's not being done because of alcohol or cannabis use, or continuing to use despite problems in the relationship, or giving up some important social, occupational, recreational activities, or using substances again and again, even though it's putting itself into danger. Continuing its use, even though you have a psychological and physical problem. See that use despite harm has been split into 3, and the impairment has been split into 2. You can see that. And tolerance and withdrawal is part of every definition you have. So the problem with the DSM is long, it's 11, but it is useful because it helps us to categorize. If only has 2 or less, fewer than 2, you say there is no disorder. 2 to 3, you call it as a mild disorder. 4 to 5, you call it as a moderate, and 6 and more, you call it as a severe disorder. That's how you can arrange it according to gradation of substance use disorder, because the treatment plan will vary. ICD-11 has come up with a very simple criteria. They grouped it all. The 11 symptoms of DSM or the 6 of ICD-10 has been grouped into 3 domains. It's very simple. One is relating to, does anybody have impaired control over use of the substance, and he has additionally craving. These are the 2 important elements that are coming into the domain, more of a psychological domain, which I think you will see in every substance, whether it is cannabis, alcohol, any substance you talk about. This impaired control over substance, what we call as loss of control or craving, is common to all substances. Or prioritizing substance use in life and persisting with its use despite problems is again a common problem that you'll see across board in all substances. The third category of tolerance and withdrawal can be present, need not be present. For example, people will argue about cannabis, whether it has really withdrawal and tolerance or not is a debatable issue. But I think the tolerance may not be there in some amphetamine type substances. It may not be there in certain other substances. But I think the first 2 domains are common across board in all substances. The third, which is the dimension of physiological features, can be present in drugs like alcohol or opioids. So that's the simplest way ICD-11 has organized. So that's the first thing that I want you to remember. So I said the most important thing is, if you ask clinically, what is the way to differentiate between use and use disorder? If somebody likes the substance, is use. Somebody wanting the substance or needing the substance is disorder. So wanting and needing the substance, there is a paradigm shift. The paradigm shift is leading to loss of control over the substance and compulsively using the substance. That's a defining thing. We shift one from liking a particular substance, like I like alcohol is different, which is called use. I want alcohol, I need alcohol is a paradigm shift. That's what you call it as a use disorder. So if you look at progression, which is you take in the history, there are 2 kinds of things that you will observe. There are people who will come and present to you when young people, very young people at the age of, let's say 25, they'll come up with a drinking episode of a longer, shorter duration, but they would have become a bad dependent pattern. And then you see the middle-aged individuals drinking for a long period of time. There is fundamentally a difference in the 2 sets of people. Young people drinking heavily. These people are drinking heavily because they end into a binge intoxication. They get into a pleasurable effect because they love alcohol, they love cannabis, they take large quantities of it. And then when they come out of alcohol and substance, they have a neutral effect. They have abstinence. In the abstinence, they are having neutral effect. They want more pleasure, so they're seeking more alcohol or more cannabis. So it's more of a reward craving. That's an impulsive stage. And this is what mostly you'll see in younger people. On the other hand, in the middle-aged, chronic, dependent people, your people always in a prolonged intoxication. They're drinking from morning till evening, small quantities of alcohol continuously. When these people actually are taking it for relief rather than for pleasure, because they are going through a lot of distress, psychological distress. They say, I'm very depressed, I'm very anxious when you don't drink, I need alcohol. And then if they abstain from alcohol, unlike the young people, they're not having a neutral effect, they're having a negative impact. They say, I'm very distressed, I'm emotionally distraught, I'm absolutely, like anxious. They are actually seeking relief from the pain or the distress. So it's more of a relief craving rather than a reward craving. Younger people seeking alcohol or substance for reward craving, the older people seeking for more of a relief craving. So fundamental difference you need to understand, because the treatment again would vary in the stages where they are seen. So that's a very important one. That's kind of basics I want to put in first before we go into the clinical approach. Let me walk you through this. How do you assess? When you start assessing, first and foremost, every postgraduate during the examination time, when you are given a case who's using a substance, a person with the lived experience of substance use, you need to understand the person may be very reluctant to talk about, disclose substance use. You may straight away say that I don't have a problem. I don't even know why you're asking all these questions to you. So he may be reluctant because he may be embarrassed, and a young postgraduate is asking a question, a young girl is asking a question to him. He may be also fear that he's being judged, or they may not see their substance use as a problem. They are indulging in denial, or they feel it's not worth mentioning to this young person. Or as a clinician interviewing at that particular point in time, the best you can do to get the information from the client is to remain non-judgmental. So that's a micro skill you all have to possess in the examination setting. You need to be non-judgmental. You have to acknowledge the fact that substance use may be indeed difficult to disclose and talk about. You need to assure confidentiality at present. Like and tell them whatever you're going to tell this person is going to be remaining confidential, is only of the person, and obtain consent before taking the history from the person. This is all very important. And then what do you do in an alcohol history? For example, this I've converted the audit into a question, and I think audit has 10 questions, if all of you know. The first 3 relate to the hazardous alcohol use. The 3 simple questions you would ask is, what's the frequency of alcohol use? How many drinks per day? Because it's a very important question. We told you 6 or more in a single occasion is a very important indicator of binge drinking or heavy session drinking. So frequency of use, how many drinks per day, 6 or more in one session, all relate to hazardous aspects of alcohol. The second set of questions relate to the dependent pattern. How often in the last year you have tried to stop it, but you are unable to stop once you started? Failed to do the job due to drinking. Have you ever had a drink first time in the morning? So unable to stop once you started, which is loss of control. Failed to do a job due to drinking, or first drink in the morning. They all indicate that the person has gone into a dependent pattern of drinking. The last 4 are relating to harmful use. Do you have guilt and remorse following a drink? Do you sit and cry and sob and say that you're committing sin by hurting your family? Or do you have blackouts? You have injured yourself or others in the process of drinking? Someone advised you to cut down drink. Have anybody who is close to you, like a physician or a family person or a close friend, advised you to stop it? These are things that you will be asking about in the history, because they are all very relevant. So it's very important to determine what he is using currently and how much is he is using. So the quantity measure should be definitely pointed out. The examiner should be very interested in knowing what's the quantity of alcohol that he's taking, for them to have a kind of a measure about what's the severity of drinking. The frequency is also very important. How many times, and then how many times in a week, daily, or whatever. What is the frequency? What is the pattern? And then you have to also understand whether the substance is causing any problems to this individual. And more importantly, it is also very important to understand the subjective experience of the person by asking him, what does he feel about his substance use? What does he think his problems are? And finally, you need to talk about any comorbidity in this individual. You also need to establish the pattern of substance use in this individual. You need to ask about the age at onset. Age at onset is so very critical, because the earlier the onset, the bigger the problem is. anybody who starts to use before the age of 18, before the brain is completely myelinated, they are in the danger of, becoming more dependent and, having more related alcohol-related harms or cannabis-related harms. So drinking or smoking up cannabis before the age of 18 is a very critical factor. So you need to ask, what is the age of onset? What's the pattern of use? Is it an episodic pattern? Is it a continuous drinking? Or is it like a stop and go back and, like periods like this? So you need to really establish a pattern of substance use. That's also is a very important one. And how often and what quantities in the past 3 months? You should also know what past 3 months and past month, because that's when you can actually recollect the data very well, and the recall bias is much less. And I think that's very useful for current treatment plan. And you also have to use what's the last time that you use, because that will really help you to understand about the withdrawal and all that. So these are all very important questions that you definitely pitch into the history, in the substance using history. So first of all, acknowledge the fact that there may be problems in interviewing the person. You have to possess the micro skills and open up and ask questions which are relevant in terms of all this, and then collect the data. And then you should also collect some data related to adverse consequences. And the adverse consequences are relating to medical problems, family problems, social relationship problems, and employment and financial problems. And also you need to understand how long has been the impairment going on, how long the patient has been experiencing these problems. This is also very important for the, like a person to, come out with. So I think it'll be a good thing to know about what is a standard drink, because many examiners are fond of asking what is a standard drink. And I think you can forget many of the things there. It's not very common in India, but if you talk about a standard drink, is a drink that contains 10 gram of pure ethanol. So what is the 10 gram of ethanol translate into? It translates into a 420 ml light beer or 285 regular beer. So that's the amount of standard drink. So in a large beer that India has, you can imagine, like it's more than, it's pretty close to 2.5 drinks. So if you look at fortified wine, a 60 ml of fortified wine, which all people think that is nothing, that also is a one standard drink. If you talk in terms of spirits like whiskey or brandy or rum, it's about 30 ml. And for like Arrack, it may be much even less than this, because we have really 40% of alcohol may be contained even less than 30 ml of Arrack. So if you look at the 10 gram of pure ethanol, it translates into standard drinks of this kind. So you really have to be understanding what you're talking about when the patients are coming and telling you what is he drinking. If he's telling that I'm drinking a quarter bottle of whiskey, you must know what a quarter bottle of whiskey contains, about 180, which means about he's already drinking 6 drinks. Which I think if he finishes a quarter bottle of whiskey, you already know that he has 6 standard alcoholic drinks. So that's large quantity of alcohol. And so you really have to really convert what people are telling into the standard drinks for your calculation. So risk associated with the alcohol use would include, like you can easily calculate it. If you have a current drinker, if he's drinking 6 and more standard alcoholic drinks, which contains about 60 grams of pure ethanol, he's at high risk. When somebody is drinking 4 to 6 standard drinks, he's at medium risk. And somebody who's drinking less than 4 standard drinks is probably at low risk. That's why like many organizations would permit very small quantity of standard drinks per week. But I think if you calculate by it, a lot of people will be actually indulging in hazardous and harmful drinking, and some people are dependent pattern of drinking. So it's very important for us to know what is the standard drinks that he has per week, per month. So we should also know in the history, we should also be able to elicit various risks that are associated with alcohol use, that include the simple things like hangovers, nausea, vomiting, aggression, reduced sexual performance, premature aging, digestive problems, anxiety and depression, difficulty remembering things and solving problems. If there are like many countries in which women drink a lot, there are many places like India itself, I do not want to mention and stigmatize that. Even people drink and pregnant women drink. The kind of fatal damage it could lead to. And sometimes people drinking heavily that lead to permanent brain damage. And I've seen a lot of people with neurocognitive impairment due to chronic use of alcohol. And I think a lot of other medical problems are also common. The association of cancer with certain alcoholic drinks, and suicide has a very strong correlation with drinking. I think in India, more than the mental health problems, alcohol dependence and substance dependence is very closely related to suicide. So we need to really understand that, particularly young people. So see, the effect of high drinking is on almost all organs, There is not one single organ which is spared by alcohol. So you need to be aware of that. It's not simply a psychiatric disorder. It's a multiple medical problem. You should be aware, and people will be presenting with many medical problems. You should be able to elicit that, just to say how severe the problem is. When it comes to cannabis, and then there are again varieties of cannabis that are available, you should be able to get the history from the person and say, what is the kind of a, like cannabis he is using. If somebody is using and saying that I'm only using bong, and he's talking about a low, like tetrahydrocannabinol content in that. So bong is usually taken as an oral infusion. And so obviously the impact of this orally taken bong may be much less compared to a smokable cannabis. So bong is something which is low in THC content. And talk about ganja, which is very common in southern India. And this is again containing less than 10% of tetrahydrocannabinol, and usually varies between 2 to 8% of tetrahydrocannabinol. And some ganja in some quantity, some places like Kerala and other places may have a better, like THC content. Charas and hashish are little more potent varieties of cannabis that you get it from the Himalayan ranges and other places, and they are having high potency tetrahydrocannabinol. Cannabis oil, which is a resinous exudate from the plant, has a very high potency of tetrahydrocannabinol, even up to 80%. And there are these days many synthetic cannabis products ranging from very low tetrahydrocannabinol products to very high tetrahydrocannabinol cannabis is available in the internet through, like you can order for it legally in this country. Some of them are very difficult to procure. So they vary in their range of THC potent. So the person should know what exactly the person is using in terms of cannabis. Even though they generically may be saying, I'm using cannabis, you need to ask what they are using. And the risk associated with cannabis includes respiratory problems are extremely common among them. And then psychiatric symptoms and disorders are extremely prevalent. Impaired executive functioning is something that very often forget about it in cannabis users. Impaired processing speed, that's why pilots are not allowed to take off the, like flight when they are having cannabis. Lower academic achievement is what we worry among school and college kids. Poor job performance, impaired social functioning in relationships. Driving ability is also impaired, which is very difficult to detect in, like alcohol is so easy to detect and then exclude when people are in driving. Very difficult with, cannabis. A lot of auto drivers in Chennai, for example, may be under the influence of cannabis when they are driving the auto. It's very, very difficult to judge them. Impaired driving ability, increased chance of other illicit drug use. Because many people believe that cannabis, because it's an illicit drug at this point in time in the country, it opens up the gate for people using other illicit drugs because the marketplace is the same. Where cannabis sold, where other illicit substance also sold. So substance dependent syndrome, you need to do a good physical examination. You need to look for signs of intoxication, probably in a case of a good alcohol intoxication. You can look for physical examination, signs of intoxication. You can also look for physical examination, signs of withdrawal in many people, like in alcohol, for example. Or you can look for liver disease, alcohol liver disease. You can look for the signs of it. So physical examination must be there. And in the physical examination, the examiner will be interested in looking at, did you look for these signs at least? You should be able to negate it. So in terms of intoxication, if the person has been acutely drunk, which is not going to happen in an examination setting, but you can come across in an emergency room setting. And these are some of the, like acute intoxication states. I'll leave the slides with all of you. Anybody can look at it. So, but then what is really relevant is, to assess for, heavy episodic drinking. I think I again and again talk about it. You can ask simple questions like, how often in the last 12 months have you had drinks to feel drunk? So this is a question relating to drunkenness. It's a very, very important question that in our research, you have realized the self-report of intoxication is a great predictor of heavy drinking. What's a noise in the background? Okay, so thank you. So the drunkenness is a very simple measure, and people can easily ask this question relating to drunkenness, and that's a measure you can actually use to predict heavy drinking. So the acute effects of cannabis use is also really important because there are good effects and bad effects. A lot of people after smoking up cannabis will feel euphoric, they laugh sillily, they have a sense of relaxation, they have a craving for sweets, they have this space-time dilatation, they'll walk for 10 minutes and they feel they walk for half an hour. They'll be, so they also feel that, they are an objective observer of their own self. It's like their own conscious observing whatever they are doing. And there is a heightened perception of visual, auditory, all kinds of perception gets very altered. That's why they listen to music. They acutely listen to music. There is a stereophonic effect on it. But on the negative side, quite a lot of people, even after smoke, even once or few times, there could be acute effects which are pathological. That includes anxiety, fear, mistrust, amounting to panic, hallucinations, delusions, and acute psychotic presentation, bizarre behavior. All this could happen, particularly in vulnerable and susceptible individuals. So you should be aware of the acute effects of cannabis use. Again, withdrawal. Withdrawal is a very important phenomena. Not only you have to look for intoxication, it's unlike in an examination setting, but in examination setting, you can look at, like withdrawal. Often people may be present to you with withdrawal. See, DSM-5 talks about, these 8 symptoms, which is autonomic hyperactivity, tremor, which is worsening, insomnia, vomiting and nausea, hallucinations, psychomotor agitation, anxiety, and seizures. These 8, any 2 of the following occurring immediately after, starting about several hours to few days, happens, and I think it can lead to impairment. That's what alcohol withdrawal state is all about, as defined in DSM-5. We, in the clinical setting, use a scale called Revised Clinical Institute Withdrawal Assessment Scale. I'm sure a lot of examiners are interested in this scale, because the way you will provide short-term treatment, these days people do not agree on a fixed regimen. People don't want to give, so chlorodiazepoxide, like a 30 milligram 3 times a day. You take it for 10 days and then tap it down. This is what we're told, 20, 30 years ago. Today, these fixed dosage regimens are not usually practiced, because you are really taxing people with a heavy dose of benzodiazepine, which is probably not required for a lot of people. So the truth is, a lot of people would want to use scale like Revised Clinical Institute Withdrawal Assessment Scale, and the whole treatment protocol is driven through the scale. And this is a very simple scale, can be administered by the nurses in any hospital. So it has the following questions of agitation, anxiety, auditory disturbance, clouding of sensorium, tremor, nausea or vomiting, paroxysmal sweats, tactile disturbances, headache, and visual disturbances. Little bit of an elaboration on the DSM-5 criteria. You can ask, you can also observe in many of the symptoms. You ask and observe and rate it, and the rating, based on the rating, which is a maximum score of 67, the total score of 8 and less is mild withdrawal symptoms, 8 to 15 is moderate withdrawal symptoms, severe withdrawal symptoms only require treatment, where the score is above 15. So the protocols that are decided according to the score on this Revised Clinical Institute Withdrawal Assessment Scale. So if you really want to be a smart person in the examination, you have to say it has to be standard scale driven, like treatment. And I think you institute benzodiazepine accordingly, then you actually are going to provide the treatment in relation to what the patient needs, rather than just giving a fixed regimen. So this is what is accepted in most settings. And you need to also remember the clinical manifestations of alcohol withdrawal has very time specific. And then I think if you have an early withdrawal, it starts immediately in 6 to 8 hours, lasts for about 2 days. Withdrawal seizures again occur within about the first 2 days, and they last for about 2 to 3 days. Usually seizures don't occur beyond 72 hours. Alcoholic hallucinosis can occur after the last drink in 12 to 48 hours. This is a little tricky issue. It need not necessarily happen only during withdrawal. Alcoholic hallucinosis can occur when somebody is actively drinking too. It may last not just for 1 or 2 days, it may last for weeks also in many people. So that's the difference between that happens in the withdrawal, and alcoholic hallucinosis can occur beyond withdrawal too. Sorry. Delirium tremens usually occurs from the 48 to 96 hours, so 2 to 4 days. And then, it may last up to the first 1 week. So I think you need to really have the time-bound phenomena to the various, withdrawal states. Alcoholic hallucinosis is very important, because often in the examination, you might have an alcohol-dependent syndrome, along with alcoholic hallucinosis. That is what usually given as an examination case. That's why I put it up very importantly. These are conditions in which the person has hallucinations and delusions in a relatively clear consciousness. So that is where it differentiates itself from the delirious state, where it occurs in an altered sensorium. Here the person is having a clear or relatively clear consciousness. So the delusions and hallucinations are mostly of the, auditory kind, whereas in the delirious type, it's more visual. Here it's more auditory. And it usually has a content which is relating to a sexual content or a derogatory content, calling me as a homosexual, calling me as a person who's a womanizer, calling me as in terms of vulgar language. These are very common, or accusing me or threatening me. So These states are not necessarily related to withdrawal from alcohol, because many alcoholic hallucinations can also occur when somebody is in a prolonged steady state of drinking. Suddenly the person presents with the hallucinosis. It can last for a few days and sometimes weeks also. So the differential diagnosis for the person would be between alcoholic hallucinosis and paranoid schizophrenia that Dr. Hema was talking about. Both of them, if you look at the age of onset, like the age of onset in paranoid schizophrenia generally, in general, is before the age of 40, whereas alcoholic hallucinosis, in my opinion, many people are in the middle age, 40 to 50 years. That's when the hallucinosis occur. Very, very rarely you see in younger people. I've seen it in younger people, but normally it occurs majority between 40 to 50 years people. And the onset of illness is very acute in alcoholic hallucinosis, whereas in paranoid schizophrenia, often it is insidious in nature. So the duration of illness is chronic in schizophrenia, whereas here it may go up to about maximum 6 months. 3 months is the usual duration. So if it goes beyond 6 months, we probably have to revise the diagnosis at times. So premorbid personality, a variety of premorbid personality is there in alcoholic hallucinosis, whereas the typical schizoid, shy, aloof, withdrawal personalities. In alcohol dependence happens over alcohol for over many, many years. I think the alcohol dependence is probably not there in many cases. If at all, it may be alcohol use rather than alcohol use disorder. And the family history of alcoholism is often present in alcoholic hallucinosis, and then it's increased in them. A family history of schizophrenia may be not evident in the alcoholic hallucinosis, and delusions and hallucinations, auditory, but sometimes it could be visual and tactile, whereas in paranoid schizophrenia, it's exclusively almost auditory. Rarely we have visual and tactile phenomena in paranoid schizophrenia. The thought content is very coherent in alcoholic hallucinosis in comparison with paranoid schizophrenia, where it can be incoherent. The effect can be very anxious, depressed, perplexed in people with alcoholic hallucinosis, where there may be blunting or inappropriate in paranoid schizophrenia many times. The intellectual functioning is very important. The fleeting memory disturbance is extremely common in people with alcoholic hallucinosis compared to, like paranoid schizophrenia. Orientation is also sometimes disturbed in alcoholic hallucinosis. These are good ways in which you differentiate between hallucinosis and paranoid schizophrenia. When you talk about cannabis withdrawal, a lot of people believe that cannabis also has withdrawal. I've seen any number of cannabis dependent young people, when they stop cannabis, they go through withdrawal symptoms. People have been using potent variety of cannabis for long periods of time. They tend to have this cannabis withdrawal symptoms. The cannabis craving is one of the important factors. Irritability, anxiety, aggression. So many of these people during withdrawal are very irritable, anxious, are agitated and aggressive. And they're restless. Their sleep is disturbed. They have strange dreams. Some of the people can also go into a low mood of depression and decreased appetite. They can profusely sweat. They can have tremors, headaches, stomach pains. Abdominal symptoms are common in my opinion. A lot of people come up with abdominal symptoms and other things. So I think the cannabis withdrawal symptoms called marijuana, withdrawal scale checklist. I think it's a very useful tool. I've employed it, and I found a lot of the people have cannabis withdrawals, particularly when used for a long period and use potent varieties of cannabis. It's not as though that it does not have physical withdrawal symptoms. So we do know there is a category called cannabis withdrawal syndrome. And mental health assessment is very important in any case of alcohol and cannabis use. If you don't do it thoroughly, you'll be seriously in trouble. It can't present just a case of alcohol dependent syndrome or cannabis dependent syndrome. Very often in the examination, they have a comorbid psychiatric disorder. That's why it's given to you. So what are the common comorbid disorders you should be thinking in your mind to examine? You should think about depressive disorders, all kind, like including major depressive disorder and dysthymia. Depression is one thing, depressive disorders. Social anxiety disorder is extremely common, and other kinds of anxiety disorders, including phobic anxieties, like panic disorders, generalized anxiety, all kinds of anxiety disorders. But social anxiety is extremely common among people with substance use disorders, alcohol and cannabis. Bipolar disorder, the association is very strong. Psychotic disorders, the one that Hema talked about. Personality disorder, antisocial personality disorder, borderline personality disorder are often an accompaniment. Eating disorders, another thing that you find with younger people these days, and other substance use can also be a comorbid disorder in these people with alcohol and cannabis dependence, more so with cannabis dependence. So mental health assessment should also include the previous history and diagnosis of treatment for any mental illness before. The family history of substance use disorder is very, very important, as well as the family history of mental disorders. Because if somebody has a family history of substance use disorder, that's the person who's more likely to become dependent on substance use. If somebody has a family history of mental illness, that's the person who's more likely and vulnerable to develop a psychiatric comorbidity. So you need to really give a lot of importance to family history. The risk of suicide must be assessed in every single case that you are given. If you are given a case of alcohol and substance use disorder, and if you are not assessed risk in that individual, you are really going to, not do very well in the examination, because the examiners will be very upset given the strong association between suicide and substance use. It's important to ask the person about this history. Have you ever thought of harming or killing yourself in the past? Do you have thoughts about killing or harming yourself at the moment? And if there is an answer to yes of any other question, you need to explore further and do a good risk evaluation of suicidal risk. I'm sure somebody will be talking about suicidal risk, and I think you should definitely assess the individual for suicide risk in every case of alcohol and cannabis use disorder. So sometimes people will be very fond of using a word called dual diagnosis, because some of the old-fashioned examiners are interested in the term dual diagnosis. Currently, we talk about comorbidity. Those days, we used to call it as a dual diagnosis. If a person has more than one diagnosis, particularly a person with a substance use disorder or substance dependent syndrome has another mental disorder, is usually referred to as a dual diagnosis or dual disorder. So you need to understand the risk of having a psychiatric disorder is 4.1 times in an alcohol-dependent individual and nearly 5 times in a person with cannabis use dependence. So cannabis-dependent person. So that's a kind of elevated risk people have for a comorbidity or a dual disorder. Usually these people are younger people, male, they are low education, they come from urban area, they have a family history of illness, mental illnesses like schizophrenia or bipolar disorder. They have a traumatic life events. These are the usual risk factors to have dual diagnosis. And the dual diagnosis is extremely critical because it is a bad prognosis on the individual, because they are the people who commit suicide more often than others. There is a greater suicidal risk among them, and the greater number of emergency room visits are also common among them. Frequent psychiatric hospitalizations are usually for people with a dual diagnosis rather than with single diagnosis, and it decreases the treatment compliance. It increases the side effects because you're going to give more than few sets of medications. They are the people who are more violent, more into legal and other problems. They get into more family instability and greater social exclusion and the greatest risk of developing HIV, hepatitis C and other infectious diseases. So I've been working with this population for a long period of time. We do know that these are the populations which are really carry a bad prognosis. Okay, so there are two kinds of disorders some of the examiners should be interested in. One is the externalizing disorders, other is the internalizing disorders. Both may be very common among people with substance use disorders. Externalizing disorders are these people with ADD, ADHD, contact disorder, antisocial personality disorder. All these externalizing dimensions are also common in one group. These are usually younger people. A young person comes to you for treatment, supposing the individual's age is less than about 30, and then he has an alcohol use history which is pathological, or cannabis use history which is pathological. Explore for either ADHD in the past or contact disorder in the past, or look at antisocial personality disorder now, and look at other things like pathological gambling. These are things that you should look for. If there is a middle-aged individual who probably has more of an internalizing dimension, you should look for depression, dysthymia, generalized anxiety, panic, social phobia, and among other disorders. So they are characterized by distress and fear. So sometimes people might have the combination of internalizing and externalizing domain. They are the people with borderline personality disorder. So that's something that you also have to be very careful and look for this. So alcohol and psychiatric disorders, if you look at it, there are many psychiatric disorders which are common among people with alcohol. Bipolar disorder is notable. Depressive disorder, social anxiety, generalized anxiety, antisocial. These are the things that should come to your mind. Younger population should actually talk about ADD, ADHD, and contact disorder. And cannabis and psychiatric disorder, cannabis-induced psychosis, that's a debatable issue, but we do believe there is an entity called cannabis-induced psychosis, and they can also have a comorbid schizophrenia, bipolar disorder, depressive disorder, social anxiety, generalized anxiety, phobic anxiety disorders. Again, younger cannabis use disorder people might have a preponderance of ADD and ADHD when they were children. So that's something that you need to really commonly bring out. So people may also be interested in knowing what are the commonly used instruments in this population. If it is a screening questionnaire, CAGE is the screening questionnaire. It's not a diagnostic tool. If you are working in a community, working in a general hospital, you want to quickly screen individuals, then you use CAGE. And CAGE is a very simple scale for screening. But audit is the one which is widely used in clinical setting. As I already talked about the 10-item audit scale, the first 3 are talking about hazard, And then the next one are talking about dependent pattern. The last 4 are talking about, like harmful use. So I think you should really be familiar with this audit score and how it is scored. And there is another scale called assist, which is used for, audit is only for alcohol, whereas assist can be used for any substance, including cannabis. And I think it's an 8-item questionnaire. It only takes about 5 to 10 minutes. I'm very fond of this questionnaire. This one questionnaire, number 1, is asking, have you ever used during the lifetime? Second question talks about frequency in the past 3 months. Question number 3 is asking about frequency of desire, strong desire, to use and then an urge to use. The question number 4 relates to frequency of health and social problems in the last 3 months. And question number 5 relates to frequency of disturbance in the role responsibility in the past 3 months. Usually, the assist is usually referring to the past 3 months all the time, whereas audit is relating to past 1 year. So they want to narrow down the, recall bias in assist. And question 6 is asking about anybody expressing concern about you are drinking or you are using substance. And then question number 7 asks them to ask about, have you ever cut down? The cutting down is a very important parameter. It's there in CAGE, it's there in assist, it's there in DSM, 5. So question number 8 is about ever injecting. Ever injecting is a bad sign. So those are the 8 questions that are there in assist. So it's a very simple scale to use. An addiction severity index is again used in clinical settings. It takes a longer time. It takes about 45 to 60 minutes. And it talks about 7 domains. Talks about the domain of alcohol and illicit drugs, psychiatric comorbidities, family and social relationships, medical history, employment and support systems, and legal system involvement. These are the 7 domains which are, done in. Some of the people, you have to be trained to administer this addiction severity index. And you need to actually do investigations in these people. The investigation in the long case should be, you should do a thorough physical examination because a lot of the people have comorbid medical problems. So you need to conduct a comprehensive physical examination, particularly in alcohol concentrating on the liver, on cannabis concentrating on the respiratory tract. So good medical evaluation, you need to probably send them to a medical doctor to evaluate it. Gamma GT is only a marker of recent drinking. It's just a biomarker of recent drinking. It only denotes that somebody has been drinking recently. So altered liver enzymes indicate somebody has an alcohol liver disease. I think the SCOT, what is popularly known as AST, is more elevated than SGPT or ALT. In the other alcohol liver diseases, the other way around is true. Whereas in alcohol hepatitis, this is a very important marker. You can just look at the lab results. If the SGOT-SGPT ratio is 2 or times more, you know that the person has an alcoholic hepatitis. That's almost a marker. So that is the ratio that I want to look at rather than the gamma GT. Gamma GT only talks about recent drinking. And then, fibroscan is a very important one that we often do. I've done it for thousands of people in Chennai, in communities. We have found out alcohol liver disease very early on in people who drink alcohol. So the stages of change is something that you need to really do when you come to treatment plans. So the question down is long history doesn't get over. With investigations, you will be asked to provide a treatment plan for this individual, because this is very important. And when you talk about, a treatment plan, you must ask the individual, the person in question, the examiner should ask the client, has a patient ever received treatment or assistance to stop substance in the past? Has a patient ever received treatment or assistance for withdrawal symptoms from any substance? Has he been treated for drug use disorder? Has been treated for withdrawal symptoms? Where was the treatment given? When was it given? What was the outcome? And what is the patient's impression about the treatment outcome? If somebody comes and says, last time I was treated, I was provided detoxification. Following that, they gave me Disulfiram. As long as they took Disulfiram, I was abstinent. You take it from me, that be the only treatment that's going to work for him. So people have to understand what has worked for him best in the past is what is best to use currently also. So I think that's something you have to ask the person before you decide. And the very important challenge is not to have a treatment that fits everybody. One size fits all is not true for substance usage. I think you need to match the person with different treatments. That's a challenge for any person. I think that's where this stage of change is very helpful. I'm sure all of you know about the stage of change. You need to determine what the patient stage is. If I'm an examiner, I'll be interested in knowing whether the patient is in a pre-contemplation stage, contemplation stage, preparation stage, action stage, or a maintenance stage. The person says, I don't even have a drinking problem. He's not even he is in the stage of pre-contemplation. He's in the stage of denial. He would require education, he would require to be engaged in treatment. What would be most helpful for him is motivational enhancement therapy. So this is where you will focus all your motivational enhancement treatment to a person who's in pre-contemplation. A lot of our treatment people, seeking people, will be in the pre-contemplation stage because they'll be brought by a family member. Somebody will be in the state of contemplation. They'll say, I need to change, I need to give up alcohol, but I don't know whether it's the right time. I think I need to wait for maybe 3 months or 6 months because I got some urgent work to do and I have to finish it up and then I'll come for treatment. So then he need to really find a way to support reasons for change. You have to make him to affirm the ability to change. Again, motivational enhancement treatment can be used in these individuals very effectively. Preparation is a stage where somebody says, I want to make a change, but I'm not too sure how to do it. What is the best way for me? Should I go to a rehab center? Should I go to Saveetha Medical College, get admitted? What's my choice? So you need to give him the menu of options and discuss with them various options and then take him on treatment. And then somebody says, I'm ready for change. And then actually you are now having the treatment plan in hand and provide a short-term and long-term treatment plan for him. The maintenance is somebody, actually I'm doing well. I've been stay sober for about 3 months, and I want to help myself to stay sober. That's the kind of a person we need to really reinforce the benefits. He has already accrued over a period of time. He has to support his ongoing treatment. You would be probably helped with some self-help groups like A and NE. So you need to really organize the intervention according to the stage of change that he's in. So another way of looking at it for alcohol-dependent individuals is used to audit, because you need to be evidence-based when you are selecting a treatment. If the score is below 7 in audit score, you just have to provide a brief intervention. Brief interventions are very, very popular. WHO's brief interventions called as alcohol education treatment is a simple intervention you can do when you have a score of 7 and below. Simple advice, again, part of the brief intervention can be also be there for people in the zone 2 is between 8 and 15. But if somebody is in a 16 to 19, you would advise, apart from the brief interventions, continued monitoring. You'd ask them, come back to me every 15 days and see me. Come back to me every week first, and then 15 days, and then every month. You just keep monitoring them over a period of time. The more frequently you see them, they are better off. The zone 4 are the people who really require a treatment plan. We have to work out and evaluate and provide a comprehensive treatment at a psychiatric setting. So those with the 20 to 40 scores. So to me, in the examination, you always provide a short-term plan and a long-term plan for most psychiatric disorders. So it is alcohol and cannabis-related disorders are no exception. The short-term plan you propose to them is to say, by saying, I need to do a comprehensive assessment. This 1 hour I spent with the patient or 45 minutes is not enough. I need comprehensive assessment, including medical examination and investigations. And once I do that, I want to offer the short-term plan. It might include brief interventions for some people. It might include motivational enhancement therapy for people in pre-contemplation and contemplation. And you need to decide whether the person can be treated as an outpatient or inpatient. You must have a clear idea of who should be treated as inpatient and who should be treated outpatient. And people with a dual disorder, people with the suicidal risk, people who are severe alcohol dependent, who are likely to have delirium, are the ones who should be put as an inpatient criteria. Most of the persons, 80% of the patients that I see are again capable of being managed at an outpatient setting. So first of all, if the withdrawal symptoms are going to be bothersome, you need to provide treatment for withdrawal symptoms known as detoxification. And once the detox is over, you need to plan the individual for an anti-craving treatment or anti-craving medication or a deterrent medication. You need to choose, I'm going to choose an anti-craving pills or I'm going to choose a deterrent pill like a Disulfiram. So you need to plan your treatment plan for managing the comorbidity. Most importantly, I would say in the short term, I would engage a family member, more than a family member, usually a female family member. They are much more trustworthy. And I would engage a wife or a sister or a mother in the treatment plan. Only then the treatment will be successful. So that's my short-term plan. And in terms of motivational enhancement therapy, some of the broad headings I want to pull out from the MET are, you need to establish rapport with the person. You need to express empathy with the person. You need to elicit patients' own perceptions about the problem. Always use open-ended questions to the individual. You need to be reflectively listening to this person, active listening and reflective listening, summarizing and giving the pros and cons to the individual, affirming whatever the patient is understood. They're all very important strategies, and eliciting self-motivating statements and recognizing and dealing with resistance, what we call as rolling with the resistance and fighting with the resistance, recognizing the readiness for change at any point in time, and increasing the patient's own awareness about his problems and providing the appropriate information advice are all critical elements of motivational enhancement therapy. So then the long-term treatment plan is also equally important. The long-term treatment plans include psychosocial interventions, particularly cognitive behavioral interventions, Contingency management is what I do. Like I do it quite successfully. Many people in Tamil Nadu do it quite successfully as contingent management treatment. My friend in Coimbatore has done a very successful treatment program purely based on contingency management. Dr. Srinivasan, extremely successful in long-term management. Anti-craving medications, I do believe in it very strongly. Naltrexone, my first choice, acamprosate, are like good medications, standard medications. And then like management of comorbidity is extremely critical. Relapse prevention is a thing that we need to think about. Family-based interventions are extremely useful in Indian setting, and I do believe that linking them with AR/NA is extremely useful in the long run. These are the long-term plans you should be considering. You see, there are a variety of things. As a physician, as a psychiatrist, I would be interested in looking at the pharmacological treatment much more closely and say which patient will be suitable for what. Disulfiram will be extremely suitable for people who are motivated, who have a co-therapist like a wife or a mother who's willing to supervise the treatment, and who are really, really ready to take this medication voluntarily. I would provide disulfiram following informed consent to them. So disulfiram will be my first treatment for those motivated, consenting individuals. Acamprosate is very important in people who are having chronic withdrawal state. Naltrexone is extremely very, very important in people who are indulging in heavy session drinking. Topiramate may be very useful in people who are very obese, and then where they want to reduce weight, you can give, but you have to understand the side effects of topiramate are extremely intolerable. Baclofen, I am very wary about it, but a lot of people are very favorable to baclofen, and it can be useful because it can be used in withdrawal as well as in dependence management, because it's a gamma agonist, and then it can be used during withdrawal as well as during. The only place where I find baclofen useful is when somebody has an alcoholic liver disease. In the presence of a liver disease, only baclofen is suitable, certainly not naltrexone. So last slide, I think people will also ask, what is the prognosis in this individual? You need to understand clinical factors like how much a person is drinking, what is the quantity, all that are not very good indicators in my opinion. Clinical parameters do not predict prognosis. I think motivation is also a very poor thing to say. Somebody is declaring, oh, he is amotivated, he is poorly motivated, not at all motivated. I don't believe in that. Motivation is a personal belief. Motivation, I believe, is a dynamic process. There are many people who will come to us on the first day and say, I'm completely amotivated. But after a treatment, they are the ones who are heavily motivated, really driven. There are people who come with a lot of motivation. After being in treatment with me for some time, they lost their motivation. They want to run away from the treatment. You see all kinds of people. I believe that motivation is a dynamic process. We need to engage them and change the motivation over a period of time. So I will leave motivation as a prognostic factor. I don't want to use it as a prognostic factor. Many people who are in the field do not believe it, do not agree with that. What we believe is very strongly, motivation is a dynamic process, can be enhanced in every individual, can be changed in every individual. Every individual can be made ready to change over a period of time. But what are most important predictors are, the longer they stay in the treatment program, the better the adherence is, their treatment is going to be better. I have clients coming to me for 3 decades. And we know that they are adhering to whatever treatment I'm giving to them. It may be a placebo kind of a medication that they're receiving from me, a benfotiamine, those days thiamine, simple thiamine, today benfotiamine, over a period of time. That's the only medication they may be taking. But they believe it's helping them. They come and see me regularly. The monthly visits are making them to remain sober. So the longer they stay, the better the outcome. Significant family involvement in the therapy, like a family member, like a spouse getting involved, or mother getting involved, sister getting involved, is the best way to show better recovery. So significant family support is critically vital in our setting. Community reinforcement means if I am recovering with another person who's also recovering in the community, that's why linkage with AA, other things are extremely helpful. The community reinforcement is a good prognostic factor. So these are the 3 prognostic factors. So your treatment should try to engage these things. How do you improve the treatment adherence? How do you improve the family support? How do you make sure that he's linked with AR/NA so he recovers with other people? So those are the prognostic factors, not clinical changes. I'm going to stop here. I know I've taken way longer than I intended to. So I'll be very happy to take any questions. I know I've been very fast as usual, but I thought people should look at the slides later on. And before I go, I'm very, very happy to take any questions that is there in the audience.
Thank you so much, sir, for that intellectually stimulating lecture or presentation on alcohol and cannabis-related disorders as ever. So, sir, there are a few questions from the student side. One is, how do we differentiate cannabis-induced psychosis versus independent psychosis, apart from the temporal correlation?
Okay. Now, I think whoever that question asked it is a bright question, brilliant question, a question that you've been alluding for, at least personally, I've been asking this question for nearly 40 years now. That was my MD thesis, and later on became an ICMR, work for 5 years. And then I still ask the question. It's not an easy answer. The easier one is to say, cannabis-induced psychosis means that person who's at question has a cannabis use disorder or cannabis dependent syndrome, and the psychosis that you see is temporally related, and the time course of the disease changes dramatically the moment a person abstains from the drug. And the moment he abstains from the drug, within about 3 months, usually the symptoms completely resolve, and so much so they go back to their original status, and within 6 months, there is no residual symptoms at all. So that's the easier one to say. So there is a temporal relationship, there is absolute resolution of and symptoms following abstinence. That's the easy thing to say. Cross-sectionally, if somebody comes before you, and you really want to say that is cannabis-induced psychosis, then it is not schizophrenia-like psychosis. That's a very tricky question. The question that you'll have to answer is, depend on the history. In many of these cases which are independent schizophrenia, there is a strong familial predisposition. There is a family history of schizophrenia. Then you'll probably watch your words very carefully and say, I'm not going to put down and say it's cannabis-induced psychosis. I'm going to monitor this guy over a period of time. Even after he abstains from cannabis, is the illness going to last longer? That's my question. And then cross-sectionally, if you see, there are people who have looked at some differences. The differences are, probably not unquestionably agreed. But these are the, 1970s paper of Thakur working in, Lucknow. He produced the paper called Cannabis Psychosis, which became like a textbook then in 74 paper. But that 74 paper said something which is very interesting. Even till today, clinically is relevant. He made few observations. The observations are, in the phenomenology, there are more affective symptoms rather than schizophrenia-like symptoms, which again reproduced by Pratima Murthy in Demands. I think a lot of people working in the field would realize the symptoms that we see. I also did my work in 5 years in ICMR. I called out more affective symptoms. Like for example, people exhibit a lot of irritability, aggression, violence, or even excitement and euphoria, and then silly laughters in this affective, so-called affective symptoms compared to a person with a typical schizophrenia. That could be one difference. So emotional sphere could be one important factor. The second, if you look at the thought content, the thought content is extremely sometimes bizarre. That's the word used always in schizophrenia, but usually it's much more like an alcoholic hallucinosis. We call it as a more coherent thinking process. Similarly, in cannabis-induced psychosis, the thinking process may be a lot more coherent. It is the formal thought disorders. We used to talk about it a lot. Thakur used to argue and say there is no formal thought disorder in cannabis-induced psychosis compared to schizophrenia. Now, the third and important factor is insight. Whereas in schizophrenia, we usually say the person lacks insight, or the insight is absent. Here, invariably, the person will have insight into his problem, at least partial insight. Maintaining insight in this present condition. Come and say, I know something is going wrong with me. I know because I've smoked up a lot of cannabis, I'm experiencing what I'm experiencing. Looks funny to me. I know I'm tripping a lot now, even though I've stopped using it. I don't understand why I'm tripping even after stopping it. So those are the so predominance of affective symptoms, particularly in terms of violence and aggression. And secondly, presence of insight or retention of insight or having a partial insight. And thirdly, no formal thought disorders and no incoherent in the thought processes. These are usually, factors that are taken. But I want to warn you, young person, that is not very, very clear. You can have another person suffering from paranoid schizophrenia with all the things that I told you, but still, that's why cross-sectionally, we can be very, very not good. So only the temporal relationship over a period of time, I've seen it. I've seen the similar presentation both. I've compared a group of people with the known diagnosis of paranoid schizophrenia without, cannabis history, and then cannabis users exhibiting with the so-called cannabis-induced psychosis, and followed them up for 3 years in our ICMR work. And we found that there was a lot of overlap. So it was a very difficult thing for us to conclude very strongly on a cross-section basis. Only a longitudinal course will be able to tell you with certainty.
Thank you so much, sir. In case of alcohol-induced psychosis, how long should we continue antipsychotics?
That's an extraordinary question, because if somebody has a very clear answer, I'll be happy. Normally, I would say that's alcohol-induced psychosis. the person stops alcohol. Like you had a history earlier to Dr. Hema. Somebody, meets with a road accident, has a trivial injury, no imaging disturbance, showed a head injury. He's also abstaining from alcohol after 6 months, develops a psychosis, unlikely to be alcohol induced because they usually want to have a temporal relationship to it. Alcohol could have played a role in triggering something, or the head injury could have been a triggering event, but I think we can't really establish a temporal relationship. But here, induced psychosis, usually we say, after stopping alcohol, if the hallucinosis or psychosis lasts beyond 6 months, you probably have to revise the diagnosis. That was the earlier guidance from many other people, experts working in the field. Today, people don't make such kind of statements. They're a little ambiguous about it, leaving us all in lurch. So I would say 6 months. After that, I'll revise my diagnosis and start providing a treatment for psychosis in general.
Thank you, sir. So, diagnosis and management of protracted alcohol withdrawal.
Oh, that I think is the greatest challenge for clinicians. In the examination, you may not be asked questions. What the examiner would like to know in alcohol withdrawal treatment is that what is that treatment you will provide. So you don't land up by saying that I'll provide, chlordiazepoxide 90 milligram per day to this individual. That answer is not liked by anybody. So you say, I will do a comprehensive assessment with a scale and decide whether this is mild, moderate, and severe and decide my treatment. Because a lot of mild withdrawal treatments do not require anything excepting reassurance. Even moderate may not require treatment just for a few days of small dose of benzodiazepine. Usually we'll provide long-acting benzodiazepines for treatment in alcohol withdrawal, either diazepam or chlordiazepoxide or lorazepam. Lorazepam advantages, you can also give it intramuscularly. Because intramuscularly you cannot give diazepam because diazepam is lipophilic. So you need to give lorazepam intramuscularly. So that's the advantage of lorazepam. These are the 3 drugs that we use in alcohol withdrawal syndrome. But you always tell the examiner, which will be pleasing to him, to say, I will always add thiamine 300 milligram to a person in withdrawal. Because you really do not want the person to have a Wernicke-Korsakoff syndrome. So you have to tell, as a good medical student, good postgraduate, that I'll add benfotiamine to this individual, 300 milligram thiamine, 300 milligram to this individual. To every single person who's having to come to you with the clinic with the diagnosis of alcohol dependence. It's a good practice to include that. In protracted withdrawal, you need to really understand, some of the people usually will say, in 2 weeks time, this withdrawal symptoms should come down. By 4 weeks, mostly the person does not have withdrawal symptoms. If the withdrawal symptoms last for more than 4 weeks, it becomes a challenge for the clinician. So I've gone through a number of protracted withdrawal, cases just because of the number of cases I've seen, number of cases referred to me. And these individuals, invariably, we need to do a good clinical examination to find out whether there is an underlying medical pathology which is actually contributing to the prolonged withdrawal state. Particularly subdelirious states are extremely common. Subdelirious states are contributed by a head injury which is actually missed. You probably had missed a head injury and the impact of the head injury unless you're called for a very sophisticated MRI. You've done an MRI, CT scan is usually what is done in the workup because that's easy to do, that miss it. So you need to do a functional MRI to really rule out, for example, any pathology in the brain or metabolic things. Often we miss serum electrolyte disturbances and other things. Infection, lurking infection in the body, a respiratory infection, for example, could also be the harbinger for a protracted withdrawal symptom. So withdrawal, lasting for about 6 months. That is the longest I had in one person, and I used to really wake up every day dreading what would happen to this person. So usually it lasts about 2 to 3 months, and within which time they are manageable, but they have a little bit of a cognitive alterations and belt disorientation, all that. So the only thing we need to pump is with thiamine and niacin, and I think managing the metabolic and other things, infections, probably many people will come out of it.
People are asking how long to give thiamine, and because thiamine dose is different across guidelines, which one is optimal?
I would say in the Indian setting, 300 milligram is ideal. In the first 1 month, definitely. So because I don't know what guidelines that gentleman is referring to.
Okay.
Dr. Jwala is asking this question. I don't know whether what guidelines he's referring to.
Okay. Okay.
But it depends on what form also you give. Is he talking about muscular, because the dose will vary if you're giving intramuscular versus oral. Oral is 300. IM preparations are 100. That's enough. So don't look at the just the dose. Look at what is the mode of administration. If it is an intramuscular administration, is 100 milligram is enough. Parenteral administration, 100 is enough. If you are looking at the oral, you are looking about 100 to 300. 300 is what I would prefer in Indian settings. A lot of people in Indian setting are thiamine deficient.
Or how to elaborate on thought content in mental status in a patient with alcohol dependence?
Thought content. In the thought content, what are the things that could possibly happen with alcohol? It's a pure alcohol dependence syndrome. The content should reflect the stage with which he is in. That's the best way to capture the stage. How else you carry the stage of this, where he is? Pure, there is no other diagnosis in this person, purely substance dependent syndrome. In that, I think the content of my mental status examination will be reflective of the stage of change that he is in, whether it's in a pre-contemplation stage, contemplation or thing. If he is a person with a comorbid disorder, then I would probably focus on the comorbid condition. Suppose he has an anxiety disorder, my content would reflect the social anxiety or a panic state. If the person is having delusions and hallucinations in a comorbid condition, alcoholic hallucinosis, my content would reflect that. So it's not a generic thing that you develop. And then if the person having cognitive disturbances, you need to really content which should talk about the circumstantiality and other cognitive impairment that the person is exhibiting. So it all depends on what the individual is presenting with, and depending on that, mental status content will vary. There is nothing like a universal thing that you will present for everybody the same thing.
So, if a student gets a case of cannabis dependence syndrome in the exam, a short case, they're asking what is the pharmacological management that they should actually tell about for
There again.
So, for the pharmacological management for cannabis dependence, what is to be told in the exam?
See, cannabis dependence, we do not have evidence-based treatment for cannabis dependence syndrome. The psychosocial interventions, particularly motivational enhancement treatments, cognitive behavioral interventions, contingency management plans are the ones which work well with cannabis dependent individual or cannabis, use disorder people. But if the person has a comorbid cannabis induced psychiatric disorder like psychosis or anxiety, we treat that. And then for other individuals, the treatment is empirical. Each one have their own choice. For example, I for one believe N-acetylcysteine, a glutamagic drug, has a great potential to be used in cannabis use disorder. My friend Hema and me are great favorites of N-acetylcysteine. She uses it for negative symptoms and cannabis use disorder. I use it for cannabis use disorder. Both of us are very convinced that it is an extremely useful tool to use in the absence of other drugs which are potentially useful in this place. I think people have used other drugs like bupropion, and they used mirtazapine. They used drugs even like naltrexone, but of no great use. I think what really, you can symptomatically use any of the drugs, doesn't matter. Suppose somebody complains of sleep and then you want to give a sleeping, medication to him. I do not want to give him benzodiazepine. I don't mind giving him a small dose of quetiapine. Because it occupies the histamine receptors and produces sleep. 25 milligram or even less than 25 milligram of quetiapine is good enough to promote sleep. So I'm only treating the symptom. I'm not treating the cannabis dependence. So I would not argue for a strong pharmacology at all. If at all, I would walk into the area something like N-acetylcysteine because there is some evidence for it. Some kind of a research evidence is emerging on that. But whereas when it comes to, and then, in other countries, they would actually give, cannabis substitutes itself. And then there are trials that are going on, and I don't want to make a mention about it because we don't even have come to the stage. In the examination, you don't want to commit on all this. Nobody is going to penalize you for not giving you an answer which only few people know. I think you should be able to give an answer which everybody knows. Everybody should know. That's what examiners are looking at. They're not going to penalize you because you didn't know the difference between NICE guidelines. And I don't really think any examiner is going to be looking at and say, what is IPA guidelines and NICE guidelines for the dose of thiamine? Which guidelines are you following? That means you are getting a super distinction here. So, but then if you don't say thiamine, that's when you are in serious trouble. And so I think you need to differentiate between the two things that you're talking about.
one last question. Like, so when do you use acamprosate? When do you commit saying acamprosate in alcohol dependence as anti-craving?
When you?
Acamprosate in alcohol dependence.
Acamprosate, I told you, Disulfiram is useful for people who are heavily motivated, who wanting to take the drug and who are willing to provide an informed consent. Because it's a deterrent medication, you have to provide an informed consent before you provide the treatment. And the treatment we normally give is about 250 milligram. That 250 milligram will be a deterrent, but not a killer. So it's a very safe drug dose to give. In my opinion, that's the most useful treatment. Acamprosate is extremely useful for people with we are coming from a relief craving. These are the individuals, when they stop alcohol, they continue to have this prolonged withdrawal in which they complain of, like, I'm feeling very distressed, I'm dysphoric, I just feel like, like restless. These are the people who are wanting something to get a relief. Those individuals who are having the relief craving, those are the people I would give acamprosate. Normally, these are the people who are, dependent on alcohol for a long period of time, and they are chronic users of alcohol, and they stop alcohol. They find it extremely difficult to stop because they're going through a distressing withdrawal symptoms, not just the physical withdrawal symptom that you talk about, also the psychological withdrawal symptoms. These are the people who are going to benefit with acamprosate. The only problem with acamprosate is the treatment compliance. Is 2 tablets 3 times a day. No person is going to be happy to take this kind of a dose 3 times a day. That's the problem with acamprosate, excepting that it produces some diarrhea and vomiting. I think more diarrhea, and I think that's the only problem. Otherwise, it's an excellent drug. It's an excellent drug. It's very useful. And naltrexone is useful in people who indulge in heavy session drinking. If the person is going to have naltrexone before the heavy session drinking, he's not going to go to 6 standard drinks. He's going to stop with even 2 and even with 3. He feels satiated. So that's when naltrexone is helpful in binge drinkers and heavy session drinkers. Versus acamprosate, which is useful in chronic users with relief craving. This is more useful in reward craving. And lastly, baclofen is useful when you want to treat it both in treatment of withdrawal as well as in dependent in alcohol, liver disease in particular. And people have an accompanying severe anxiety. That's when it's very useful. Topiramate, extremely useful drug, but for its paresthesias, very uncomfortable paresthesia it produces with the dose that is required to treat alcohol dependence. 150 milligram and above is what is required. But that dose, most people develop paresthesia. But that's very useful when somebody wants to shed some weight off. So that's where you'll choose the drugs.
Thank you so much, sir, because there are a lot more questions students have been asking, but we will compile it and we will email them, sir. There are a few more
please
questions.
email, I can provide the answer to them, and please use the slide, and I don't know, but tell me the, PowerPoint. I mean, I can send it to any address that you want. You can distribute it.
No, sir, definitely, sir. Once we get it to our mail ID, we will just post it to all the students, sir. So thank you so much, sir, for spending a valuable time and input for the students for the clinical examination preparation. We sincerely thank you again, sir. It's an honor to have you as a speaker. So thank you so much, sir.
Thank you, Dr. Raman. I want to thank Dr. Chandalekha and Dr. Shanti Nambi, both close friends, for inviting me to this meeting. Thank you so much.